Well, I'm very, very happy to be back in Kyoto. And when I was here the last time, I think I gave you a thought about what the Obama administration might do. And today I'm here to tell you about what the Obama administration has done. And the plan to spend $44 billion, 4 trillion yen, on electronic healthcare records. And my experience from February until now, August, in actually trying to spend this money both quickly and wisely. See, in the United States, the economy has not been so good. And so the Obama administration wants very much to give significant funding to doctors, to hospitals, to vendors, to everyone who will build a safer, more quality-oriented, electronic, healthcare-connected world. But we have to do it right. So it's not just about hardware and software, giving doctors more technology. It's more about making sure they use it correctly. So before this lecture, I met with the translator and I said, there's going to be a very strange term that I'm going to use. That term is called meaningful use. Now that's a very peculiar term. When I was here in February, meaningful use didn't even exist as a concept, and now it is the most important term in everything that's being done in Washington. Meaningful use is how a doctor, how a hospital, how a nurse uses electronic systems to deliver good quality care. The $44 billion, the 4 trillion yen, is all about paying doctors and hospitals for the meaningful use of electronic health records. So let me contrast this to what the Bush administration had said. Oh, do you want to do simultaneous translation? That's right, we should probably do that. Sorry. Let me stop. You can summarize what I've said, and then we'll do breaks in between. So the Bush administration, and by the way, everything the Bush administration has done has now been declared wrong. So we have changed completely. Said we will establish an office to coordinate all of healthcare IT and give it $50 million. That was the total budget for the entire country, $50 million. Here, I'll turn it over to you. And then we will create a federal committee called the American Health Information Community, and it will decide what are the use cases. That is, imagine that H1N1 flu occurred and hospitals needed to send information to public health, and there was a very specific plan for coordination. Now, that would be so specific to H1N1, it wouldn't be usable for any other possible outbreak in the future. These use cases were extremely detailed, took months to create, and were extremely specific. And then we'll create a group, the Certification Commission on Health Information Technology, to certify thousands of features of electronic health record products. Now, I will tell you, the problem that occurred with this is it created so much of a burden for vendors creating electronic health records, they stopped innovating. And all they did was work to meet the criteria, the thousands of criteria proposed by this commission. And then we'll do an inventory of every privacy policy in the United States. Now, the problem we have in the United States are state laws preempt federal privacy law. And this means that we don't have a federal privacy policy. We have 50 of them. Now this group, the Health Information Security and Privacy Collaboration, simply made a list of all the 50 state laws for privacy, didn't attempt to create a single, complete privacy policy for the country. It's just a list. Now the Health Information Technology Standards Panel, which I chair, is actually the one thing that survived the idea that you would put all of our vendors, all of our attorneys, government, payers, patients, and all would figure out together and collaboratively what data standards to use for sharing information securely. That has continued from the Bush administration forward. This other activity really has not. So if I were to summarize the 4 years of the Bush administration, the focus was on the products and the technology, and not on the doctors, the patients, or improving health. So here is the Obama administration's plan that was enacted in February, just actually 4 days after I left Kyoto, and the work that we've done from February to August. So the Office of the National Coordinator, remember it used to have 50 million, it now has 2 billion. So you may ask, what will be done with that 2 billion? The 2 billion will not be about products and technologies. The 2 billion is about getting doctors and nurses to do their work electronically. And that is training, making sure that there are regional teams of experts that will help hospitals and doctors use technology in ways that will improve healthcare. And you'll see in the next few slides a description of exactly the focus. How do we ensure that medication lists are accurate? How do we ensure that diabetes is treated appropriately across all diabetics in the country, regardless of what doctor they go to, their income level, their educational level, or their race ethnicity? So there are 2 committees, federal advisory committees, created to help the Office of the National Coordinator do this job. The first is called the Health Information Technology Policy Committee. It has 3 work groups. The first work group helps define what it is to use technology wisely. What is it we should do so that doctors and nurses improve health? The second is what can we do to accelerate their training? And what should we focus on to make sure, it's not so much technology, to make sure the products are useful, whereas the Bush administration said, here are thousands of features. This new work group, the certification work group, will focus more on is privacy protected and can systems exchange data so care is coordinated. And then finally, the Health Information Exchange Work Group, how do we share data between doctors and doctors and doctors and patients as a country? How do you decide that quality care is actually being delivered? Now, this is actually a hard problem. What we ended up doing was deciding that there are 38 data types that you might gather from every patient visit, such as what medications were given or what diagnosis was made, and certain attributes, certain aspects of those data types, like if we care about was say an emergency department visit, was an aspirin given within 20 minutes of a patient arriving with chest pain, was antibiotic given within 30 minutes of a patient arriving with pneumonia. These kinds of measures would be gathered electronically. The Clinical Operations Work Group sets the data standards so that doctors can communicate problem lists, medications, allergies with each other. And Security and Privacy provides all the data standards so the patient can control what data is shared according to their preferences and state and federal law. Overall, there's a much stronger role for government in the Obama administration plan. The federal government's National Institutes of Standard and Technology, NIST, will test all of these standards to make sure they work. and will also oversee multiple organizations that will test products to make sure they're good enough. That is, they comply with privacy and security requirements and data exchange requirements. That CCHIT organization that I mentioned from the Bush administration, Certification Commission on Health Information Technology, is just one of what will be many organizations testing products. So it has a very different role. So what the Obama administration has decided to do in detail is set specific objectives for 2011, 2013, and 2015 for doctors to achieve this meaningful use, this appropriate improvement of health care through the use of technology. And then each doctor in America will be paid $44,000 if they have achieved these goals. And it's a bit complicated, but you get $44,000 if you've achieved them by 2011. $35,000 if you've achieved them by 2013, and by 2015 you start getting charged. You will get less money from the government. Your Medicare rates go down if you are not doing these things. Oh, and by the way, every hospital in America will get $2 million per year for 4 years for the same kind of achievement. Now, what does a hospital or doctor have to do to claim these dollars? They have to maintain a current problem list electronically on every patient, encoded in SNOMED CT as a vocabulary. They have to maintain an active medication list for every patient, encoded in a specific electronic vocabulary, RX norm. They have to maintain an active allergy list. Vital signs have to be recorded. They have to achieve laboratory ordering and resulting electronically. And for every patient, they need to record the characteristics we're concerned about to make sure that every citizen receives equal care: race, ethnicity, gender, insurance type, and primary spoken language. Every outpatient encounter must be documented electronically, and that note the physician writes must be available electronically to the patients. So you'll see in the next few slides, there's a huge emphasis on sharing data with the patient. So imagine that every note you write, the patient would see. And every order that is entered in a hospital will be done electronically. Now, this goal was softened a little bit. The current meaningful use criteria for hospitals is that 10% of all orders must be entered electronically in 2011, 100% by 2013. But every prescription written in an outpatient clinic must be electronic by 2011. But here's an important concept. If I were to ask Dr. Yoshihara, do you have just one software system in the hospital that runs everything? My bet is you have many software systems. You have data warehouses. You have lab systems and pharmacy systems. Whereas the Bush administration may have said, you need a certified system. The Obama administration will ask, can you, with your many systems, achieve these kinds of things? Though it might be an iPhone application, or it might be a data warehouse. Can you, as an organization, do these things to improve care? And if so, you get the money. So you may have seen in the newspaper somewhat controversial issues about healthcare reform in the United States. In the United States, we currently spend about $8,000 per person per year. We have a lot of care, but we don't have a lot of quality. for the results they achieve as opposed to the tests and procedures they do. And so these are some of the measures that we'll gather as evidence that a doctor or a hospital is delivering good quality, coordinated care. Such as, let's look at hemoglobin A1C for every diabetic in the United States. Let's take a look at blood pressure measurements for every person with blood pressure that's elevated. Let's look at cholesterol and make sure that patients are given appropriate cholesterol, either modified diets or medications to reduce cholesterol. Let's stop smoking and make sure patients are told about the health problems associated with smoking, and so on. Make sure that they have vaccines, make sure that they are given medications such as aspirin, they have a heart attack. Let's make sure we don't confuse our elderly by giving them medications that are known to cause mental status changes or other problems. And let's make sure that every time we measure quality, we're reporting it by race, ethnicity, age, gender, insurance, to make sure there is no discrimination, that there is equity in all care. So I mentioned a real focus on patients and their families. Now, we're all patients. So at every encounter, there should be a summary available to the patient. The patient should be able to transport their electronic data from hospital to hospital, from doctor's office to doctor's office. The patients should have access to good quality electronic educational materials. All of this should be driven such that the patient is considered the owner of the record rather than the doctor. It's a very different idea. Now, let me be honest here. My mother tends to read my email because my father prints them out on paper and she reads them and then handwrites a response. I'm not sure she would really enjoy managing her healthcare on Google Health or Microsoft Health Vault. So I believe that this is very, very important to engage the patient, but we need to both give patients access to their records and share records electronically from doctor to doctor with patient consent. So for every one of these goals, there are a set of electronic measures that prove that the doctor and the hospital are actually doing what they're required. I just list them in this presentation for your reference.
でさっき言いました通り、医師、病院が、要求されている通りの治療の行為を行っているということが証明できるように、電子的な数値測定、反測定、成果の測定がされるというふうに言いました。このお話をいくつかすがる。
In the United States, we don't have a healthcare system. We have disconnected hospitals, doctors' offices, labs, and pharmacies. So to solve that problem, because we're not likely to get a national healthcare system like Canada or the United Kingdom, we want to ensure that doctors and payers, all of these pharmacies and labs can exchange clinical information, and especially focus on the medication list. That at every encounter, outpatient, inpatient, or emergency department, we have an accurate list of the medications you're actually taking, not just the medications you were prescribed. It's very often patients don't take the medications they're asked to take. And a set of measures, as I described for the last information, such as if care is coordinated, we would expect we'll keep patients out of the hospital. That if you have a patient with congestive heart failure that keeps coming back to the hospital every 2 weeks, that suggests their care isn't coordinated very well. They may not be taking their medications as we would like them to. They're not being visited by a home nurse. They're not being kept healthy. So we'll measure the readmission rate. We'll make sure that medication lists are being gathered effectively. The data is being exchanged with patient privacy protection Very similar to what you're doing at Kyoto University with the patient giving the authority for doctors to see and share information. And we'll make sure that between 2011, 2013, and 2015, that more and more information is shared. Doctors will only be paid if they're actively using electronic data exchange. Not only is care patient to doctor or doctor to patient, it is also a population. We're concerned about public health, such as H1N1 or other outbreaks. We're concerned about lifetime immunizations. Back when we were talking before the lecture, I asked you if you had a list of your immunizations that you could just immediately produce. Well, I can't either. So how do we ensure that the country has an electronic immunization registry that we can pull up every person and the vaccines they've received? How do we report not only infections, like H1N1 that's diagnosed, but symptoms? What if you go to an emergency department with fever, muscle aches, cough, and a history of a recent visit to Mexico? That should probably be electronically gathered so that the Centers for Disease Control know about the nature of outbreaks. Now, President Obama, I think, actually had an embarrassing moment when he reported that there were only 4 H1N1 infections in the United States at the same moment that Fox News was reporting 13. And this occurred because we didn't have a fully electronic monitoring network for the symptoms of H1N1.
患者さんから医師に対する情報共有、医師間の情報共有等の話をしてきましたけれども、国全体の話にちょっと。
So everything I have just described, the measures for quality, the coordination of care, the population health, will become law by December 31st of 2009. In the Bush administration, the idea was we're going to come up with several ideas and hope that doctors use technology wisely, and hope that the implementations go well. In the Obama administration, I mentioned, there's more government involvement. There's $44 billion, and it is the law to do what I have just outlined. December 31st, the end of the year. Because I want to leave some time for questions, I'm just going to skip a few slides because we'll cover the material here. How do we make all of this happen electronically? Well, over the last 4 years, HITSP, the Health Information Technology Standards Panel, worked on what I had called before use cases. Very complicated ways in which we would exchange data. They were very, very specific. What we now see with meaningful use, with the Obama administration, we have to come up with what I'll call electronic capabilities. Not very complex use cases, but basics, such as how is it you write an electronic prescription? How is it you get a patient the information about their clinical summary? How is it that you submit a quality measure to the public health or other government entities? These are 30 specific electronic transactions. They are all available for you to see in the public domain. They're at HITSP, hitsp.org, and all of their details are described with every standard we selected to make these easily achievable. To give you an idea of how much work this was, between my last visit to Kyoto and producing this work for the Obama administration, took 17,000 hours of effort by 700 organizations to create all the data standards that are necessary for the Obama administration plan. But there is a problem, and Dr. Yoshihara knows this well, which is, if I were to ask the question, is HL7 version 3 clinical document architecture and all of its complexity ready to be deployed in every doctor's office tomorrow. You might say, 2013? Okay. Get every doctor's office running in the most complicated standards that have come from IHE or HL7? A little bit hard to do by 2011. So we had to come up with not only the standards, but a level of readiness for every single standard. Is it so mature that every doctor could be running it tomorrow? We know what it will cost. We know how hard it is. Or it's good work, but it's new. We need to wait for 2013. It was just invented, and we have no idea how hard it is to deploy. Or we haven't even figured it out yet. And so you'll see in all the materials that the Obama administration is getting 2 weeks from today, we'll have every single standard and a measure of its readiness to deploy. That will be available to you on the web. That will be coming from the Health and Human Services, the government website. But getting this done is actually very hard. So imagine that we want to measure across the United States every single patient at high risk for a cardiac event, say a heart attack, and ask the question, have they been given aspirin? Well, that sounds like a very good goal. Reduce heart attack risk. Make sure that people post-heart attack are getting the medications that we know will help them. Well, how do I define what is a high risk for cardiac event patient? There's not a standard exactly for the definition of high risk. Aspirin is not a prescribed medication. What if a patient goes to the local Lawson and buys a bottle of aspirin? How am I going to know? Well, the patient will have to self-report that they went down to a store, a Lawson station, and bought aspirin. But there isn't a standard for patients to self-report the medications they bought over the counter. So those are some issues. And so fine, for 2011, we'll use some standard codes that we use for billing or SNOMED CT to help us figure out who's had a heart attack, who might be at high risk. We will use e-prescribing standards to figure out if a doctor or a pharmacy wrote for or dispensed an aspirin. But not all of these standards are yet widely deployed in the United States, so we have some for 2011, some for 2013, and some for beyond. Let me conclude with some statements about privacy and security. I know that privacy and security of electronic health records are extremely important in Japan. And in the United States, they are foundational. Unless we have patient trust to exchange data, it will be very challenging for any of the Obama administration's plan to be successful. So here's an example of the kinds of privacy and security standards that we'll use. Now remember, I came up with a 1 to 4 category of how ready we are to deploy them. So this shows you examples. Well, if we are going to have every single patient preference recorded and doctors only able to see data based on patient preference when it's shared between organizations, are we quite ready to do that? Well, the answer is not quite. This is a level 2, and it'll take until 2013. Are we able to do the basics of usernames and passwords and ensure doctors with the right credentials can get access to clinical data? Oh, well, yes, we're ready to do that using SAML, the Security Assertion Markup Language. That's a category 1. And so on, that for every operation involving privacy and security, authorization, audit trails, sending data from place to place, we have chosen standards for every single aspect of privacy and security. And many of these standards are the same standards that would be used by Amazon or Google or any commercial provider outside of healthcare to secure their information systems. To go from a technology focus to a doctor, nurse, and patient focus, to go from a focus on certification of software to more of a thought about how do we share data and ensure privacy and security. To go from $50 million of spending to $2 billion plus $44,000 per doctor, $2 million per year per hospital, all told $44 billion to accelerate healthcare information technology. And next time I visit Kyoto, I'll tell you how well it worked, or not. Happy to answer your questions.
質問がたくさんあると思います。予定の時間に迫りつつありますけど、延長はままないと思いますので、どうぞ日本語で気楽にですね、質問をしてください。で、どんどん翻訳していただきます。いかがでしょうか。
4月にニューイングランド・ジャーナル・メディスンで、アメリカの EHR の普及率が約 2% であるというふうな報告がありましたが、具体的にオバマ政権では何%、もちろん全部だと思うんですが、をターゲットされているんでしょうか。
What a great question. So first, Ashish Jha, my colleague who wrote that article, was too harsh. He said 2%, but the criteria he defined were extreme. It was basically everything I had outlined in these slides. Reality is it's probably more about 15%. So David Blumenthal, our national coordinator, was asked, what is the target? And he said, I will not answer that question. But I can tell you, having been involved last time I was in Japan with writing a lot of the legislation, the target is 70% of all hospitals and 90% of all doctors to have achieved everything in my slides by 2014. That's the goal. So David Blumenthal won't admit it publicly.
今ですね、HL7 バージョン3、バージョン3の、CDA がリリースするというのが現バージョンだと思うんですけども、すでにHL7 コミュニティの方ではですね、バージョン3、バージョン3の開発に入っているわけですね。で、2000年から今に至るまでの間で、実は、1、2、2つバージョンがあっても、おそらく2000年代で3が出てくるわけですね。で、そうしたときに先ほどのタイムスケジュールからどの企画のどの、部分がですね、実際に例えば使えるとか使えないという判断されると思うんですけども、そういう企画のバージョンというのは中に非常に織り込むとしたらどういう考え方で織り込んでいくのかというのを、お聞きしたいなと思います。
Another very good question. So we've had to be very realistic about requiring standards because there are 500,000 doctors in the United States, and for them to upgrade as rapidly as standards are created is not possible. So what you'll see in the August 21st materials we deliver to Health and Human Services, in 2011, we will allow HL7 version 2 as well as the CCD, that is the HL7 version 3 CDA release 2, but we'll require the CDA release 2 by 2013. And then, of course, release 3 will come out, and that eventually will be required. But assume that there's going to be about a 4-year lag between the standard being created and adoption being required. That's just realistic.
ブッシュ政権からオバマ政権に行ってテクノロジーフォーカスからドクター・ナース・ペーショントフォーカスに移ったというのがポイントでの一つで、それからブッシュ政権ではテクノロジーをサーティファイしたのに、今度はシェアリング・オブ・データに置いたというのはよくわかるんですが、第一の質問はシェアリング・オブ・データっていうのは、異なる医療機関でですね、それに関しての標準はもうできてるんでしょうか。いや、シェアリング・オブ・データっておっしゃったんでね、どういう標準を取るべきだっていうことは決まってるんでしょうかっていう質問です。で、2つ目はそれに関連してですよ。1つです。はい。
And so what you'll find at hitsp.org is this list of all of the data standards for problems, for medications, for allergies. Remember that the data standards are a few types. There's how do I actually represent the contents, like the medication name and the way that it's taken. A vocabulary. How do I name the medication so that whether it's at Kyoto University or Harvard Medical School, it is understood what that medication really is? And then how do I securely get data from place to place? So you'll find this exhaustive list of specific standards taken from HL7, IHE, and other standards development organizations, but also implementation guidance, very specific rules on how each standard should be used.
もう一点は全然違う観点からですが、メディアではですね、アメリカのメディアも言ってるんですけど、このオバマヘルスケアプランが民主党の中からも反対があって、先ほどおっしゃった2009年12月31日に成立するかどうかを危ぶむ見通しもあります、見通しも出てますが、何が具体的に反対されてるんでしょうか。今の
保険です。特に保険の話。
その辺をちょっと。
So the challenge is the United States now has private insurance companies that are employer funded. It's happened after World War II. And this is considered something politically challenging to disrupt. And so it's really about the insurance aspects of how care gets paid for. And it's unfortunate that there's a lot of lobbyists that claim if private insurance companies are changed in any way, we'll end up with care such as Canada and the UK have today, with waiting lists and less choice than Americans are used to. That's the chief objection. I do believe that aspects of our healthcare reform plan will succeed, and I look forward to September when Congress returns from recess and the debate begins again.
Thank you.
ブッシュ政権からオバマ政権への政策の転換というのは非常によく分かったんですが、医療現場の医師がこの変化をどのように評価しているのでしょうか。特に、例えば2011年あるいは2013年までにこのようなことをしなければいけないというリストが示されて、それが達成された場合の報奨金というかアワードも示されていますが、逆にある意味では達成できなかった場合のペナルティというのも出てきたというあたりを、医療従事者がどのように受け止めているのかということについて教えていただけると思います。
These are great questions. So here's the challenge I have. I run several Harvard-associated hospitals, and we have about 1,500 doctors inside the hospital and 1,500 doctors outside the hospital who are in private practice. Those doctors are coming to me and saying, what? You want me to spend $50,000 on an electronic healthcare record, and in 2011, I may not get paid? You, the hospital, should pay for my electronic record, and if I'm successful, record systems for these doctors in the community so they are insulated from the risk you describe. Now, the law in the United States does not allow me to fund 100% of the doctor's electronic record in a private practitioner's office. I can only fund 85%. So I've arranged for the hospital to pay 85%, a physician's organization to pay 15%, and the doctors keep whatever monies they will get from the stimulus package if they achieve meaningful use.
医療情報を電子化していって、患者中心で共有していくっていうお話だったかと思うんですけれども、お母さんの話も出ましたけども、老人、年老いた方とか、あるいはサラリーが少ない低所得者の方とか、医師から医師にと病院から病院で情報を共有するようないろんな話が出てたと思うんですけれども、一つの方は教育であったりだったと思うんですけども、そういった方たちにこの改革というか、仕組みを、使ってもらう、あるいはうまく動かすためにどのような具体的な対策を考えていらっしゃるのかをお聞きしたいです。
それはツールとか
方法であったり、補助であったり、いろいろあると思います。
So let me explain what we did in Massachusetts. We developed educational materials, which I can send you a copy of, and you can share them as you wish, to explain to patients the benefits of data sharing and be honest with them about the risks. And ask the patient, this is a personal decision. Do you believe that when you go to the emergency room, if a doctor can save your life by knowing your complete medication list, by knowing your mental health history, by knowing any issues you may have of substance abuse, what do you want to share in that particular circumstance? If you share nothing, you could have a drug-drug interaction problem, you could be misdiagnosed, you could be harmed or die. If you share everything, you will probably get the best quality treatment, but it's up to you. And so what we do, we've sent all of the citizens of Massachusetts these educational materials and asked them to sign and put their preferences on this form. Currently, we've had about 95% of the patients in Massachusetts agree to share everything. And for those who don't, it's fine. We adhere to their preferences.
多分今のご質問と少しニュアンスが違ったかもしれないけど、要するに、D2C の話ですよね、今言われたらそういうことですよね。要するにどうやって患者が自分のデータを見るかと、しかし非常に不安な人もいるだろうというふうなことなんですが、そこについてはどうなんでしょうか。
Right, so another great question. There is a digital divide in the United States. We've done surveys in Massachusetts, and about 20% of patients have difficulty finding internet access. These days, wireless is everywhere. Of course, our system is not as good as the one in Japan, but we have wireless, we have libraries, we have the workplace, and so we have said that we will not only use the internet and make networks a mechanism to access data, but even putting data on a CD, putting data on a USB drive are acceptable ways of giving data to patients electronically. 2011 gives a fair amount of latitude as to the electronic format. In fact, in 2011, even giving the patient a PDF is okay. But we do believe, going forward, increasingly patients will have access to the internet. Digital divides will continue to diminish with free wireless, free community service kiosks. And so probably by 2015, we hope the idea of using a personal health record offered by your doctor or a Google or Microsoft or other product should be fairly universally available.
じゃあ最後の質問という
原さんどうもありがとうございました。ちょっと戦略的なお話なんですが、世界中の医療の中でエフィシエンシーとイコリティとそれからエフェクティブネスという3つの E を同時に実現した国はないと言われているわけです。何か2つを選ぶだけで3つを同時に満足させるという国はなかった。しかし今日のお話を聞きますと、そのピープルセントリックもしくはペーシャントオリエンティッドな EHR を作り上げることによってその3つを実現しようとする、ものすごく大きなチャレンジというふうに理解をしたわけであります。ただその実現のためには相当これまでのアメリカのマーケティングメカニズムによるその医療ではなくて、むしろトップダウンのそのフェデラルガバメントによる相当大きなその力がいるわけでして、それを医療機関がついていくためには何らかのインセンティブがいる。そしてそのインセンティブはHalamkaさんは言葉としては言われませんでしたけれども、Pay for Reporting であるとか Pay for EPR であるとか Pay for Performance であるとか、そういう新しいその経済的なインセンティブでそれを引っ張っていこうという考え方と理解しましたが、それはそれでいいのでしょうか。もしそうであればですね、メディケアやメディケイドはできるんでしょうけど、HMO はそれに従うとはちょっと思えないんですが、その場合はどうすればいいでしょうか。
So you're exactly right. And that is, it is all about aligning incentives by changing healthcare payment systems. Specifically, instead of paying doctors for the quantity of healthcare, paying them for the quality of healthcare and the comparative effectiveness of healthcare. So in the United States, I hope this isn't true in Japan, we have direct-to-consumer advertising for pharmaceuticals. It's awful. So a patient sees a television commercial and goes to their doctor and says, I saw this expensive new pill. I want one. Well, the doctor is paid regardless of they're using an inexpensive pill, an expensive pill, an effective pill, an ineffective pill. Healthcare reform will focus on paying for those treatments and medications which have value. That is, the quality, the efficiency, the effectiveness over cost. Now, people worry that this is going to result in rationing of care. And I don't think it's going to be rationing. I think it's going to be just evidence-based comparative effectiveness. And AHRQ, the Agency for Healthcare Research and Quality, has been given $1 billion by the stimulus package to look at these areas of efficiency and comparative effectiveness as part of healthcare reform.
じゃあまだたくさんあると思いますけれども、もう30分を申し訳ありませんので、タクシーも待ってますので、これで終わりたいと思います。そういった話が、Thank you very much. Thank you. 金曜日、しかも8月のバケーションの季節の金曜日の夜にこんな人が集まると気違いずに地味という話がされていましたけど、日本人は初めて驚いて、じゃあまたよろしくお願いします。ありがとうございます。